Thank you. Thank you to Team Diabetes India for giving me this amazing opportunity and making me a part of this amazing lineup of esteemed faculty that we have here today. Today, I'm glad to present my opinion on the topic whether periodontal therapy should be standardized as part of diabetes management plans. Let me start with some stats which makes it undeniable. Periodontal disease is highly prevalent in patients with diabetes. Studies have reported a prevalence of between 46 to 90%, which is nearly double the rate of periodontal disease in patients without diabetes. Multiple international health organizations have acknowledged this relationship, including the American Dental Association. Even the American Diabetes Association has recommended that patients be referred to a dentist for periodontal examination as an essential component in the Standards of Care in Diabetes 2025. If that was not evidence enough, our very own RSSDI guidelines, penned by none other than Dr. Bansi Sabu, Dr. Manoj Chavla, Dr. Sujoy Ghosh, to name a few, have also emphasized the importance of including periodontal therapy and periodontal examination in order to achieve better outcomes for our patients. So, I would just like to begin by saying that periodontal disease does not just affect your teeth or your gums. It has systemic complications involved too. In fact, periodontitis is considered to be the sixth complication of diabetes. And the bacteria that cause gum disease or periodontitis, they don't stay restricted to your gums. They enter the bloodstream and create a systemic inflammatory response. This inflammatory response can increase insulin resistance and hence hamper diabetes control in our patients. Periodontal disease has also been found to have multiple other systemic inflammatory effects, ranging from halitosis to heart disease, respiratory disease, and many more. In fact, pathogens associated with an unhealthy mouth are the same as those associated with multiple serious systemic diseases, including but not limited to Alzheimer's disease, diabetes insulin resistance, adverse pregnancy outcomes, and even cardiovascular diseases. Apart from the obvious ways in which periodontal disease can cause diabetes control, there are a few more. First, it can lead to loss of teeth and difficulty in chewing, which will compromise our patient's nutrition, and this will lead to further poor diabetes control. Loss of teeth can also trigger feelings of anxiety, stress, and low self-esteem, all of which will negatively impact a person's quality of life. And a lower quality of life will further lead to poor glycemic control. Let me answer common questions that might come to everyone's mind. First, are the two diseases really linked? Yes, there is a bidirectional relationship that has been established, and a rise in one can lead to a rise in the other. Second, does periodontal disease really affect diabetes control? Yes, periodontal disease can cause systemic inflammation and enhance insulin resistance. Third, will improvement in glycemic control alone improve the patient's periodontal condition? No. It can prevent further progression of the disease, but it will definitely not reverse the disease. And fourth, can periodontal therapy really improve glycemic control? Yes, periodontal therapy has been shown to have a positive effect in improving glycemic control by reducing A1C levels by 0.5%. To put things into perspective, this effect is similar to what is achieved by adding a second line oral medication. Look at this picture. What is the first thing that you notice? Well, let's take a closer look. Even though this person was also missing an eyebrow, I think one of the first thing that most of us noticed was his missing tooth. This just goes on to prove how important your smile is, how important a healthy smile is. And I think Dr. Ramakrishnan, I think he made a very good point about how important it is. Let's take a look at some familiar faces to prove my point. This just emphasizes how important a healthy smile is and how it can shape one's personality. Think of your body like a cricket team where all the organs are working together for us to win the game. If the batsmen and the bowlers are playing well, but if the fielders are letting balls slip by, we might end up losing the game. Similarly, if we ignore periodontitis, we might risk losing the diabetes game. Many people might argue that providing periodontal therapy for our patients would be expensive and time consuming, but let me put it this way. It is far easier, far cheaper, and far less time consuming to treat periodontal disease now than to treat the systemic and local complications that it might present if it is neglected right now. Incorporating dental and periodontal checkups and periodontal therapy can significantly reduce bacterial load and systemic inflammation and will help in preventing future complications. I believe that as we move into an era of providing personalized and holistic care to our patients, it is not just essential to provide periodontal therapy to our patients, but it is absolutely essential. Thank you.
Thank you, Chairperson, for kind introduction. And out of box, thank you, Dr. Bansi sir, organizing committee and scientific committee for providing me this opportunity. So my role is very simple. Should a periodontal therapy or a examination in a standard as a part of diabetes care management plan? So should we make it a standardized? We'll just go through it and I'll put my perspective before immense audience. So diabetes management is a multi-nodal therapy. Like we say, diabetes education is much, diagnostic facility should be there, individualized treatment should be there. It's not like fit one shoes to all. Prevention and management of complication by screening, by treating it, and lifestyle advice is the first priority. So whether periodontal therapy or a disease treatment should be a mandatory part of this plan. Despite the controversial connection between the periodontal disease and the diabetes, it should not be standardized as a part of diabetes management plan. Why? Why? Because there is a lack of conclusive evidence of the causal link. Why? Because some studies show that the link between the diabetes and periodontal disease, but causal relationships are not well established. Either the oral disease, which is increasing diabetes, or hyperglycemia, which has impact on the oral cavities. So some studies suggest that the periodontal therapy may marginally improve the glycemic control, but evidence are mixed up. Why the evidence are mixed up? Because in Diabetologia in 2011, one paper was there which suggests that the periodontitis and diabetes are two-way relationship. Existence of a two-way relationship between the diabetes and periodontitis, with the diabetes increase the risk of periodontitis, and periodontal inflammation negatively affect the diabetes control. Some another paper in the World Diabetes Journal in 2015, they also try to establish the relation between the diabetes and periodontal infection, where effect of the periodontitis and its treatment of the diabetes metabolic control are not clearly defined, and as a result of the study remain controversial. Another study, Diabetes Care 2010, effectiveness of the periodontal treatment on a glycemic control of diabetic patient, suggests that the presence of meta-analysis periodontal treatment lead to an improvement in the glycemic control in type 2 diabetic patient for at least 3 months. So this is in support of treatment. Whereas the effect of the periodontal therapy, like in the J. Collin Periodontal Journal, it suggests that the no statistically significant difference were found in the changes of HbA1c levels between the test and the control group. No surgical periodontal therapy improved the magnitude of change in periodontal parameter as compared to the control group. So again, it's question mark, improving diabetes with periodontal treatment, it's there or not. Okay, this is like a link we have to look after, but where is the resources? Resource allocation and financial burden, another aspect of treating periodontal disease in diabetes. So diabetes patients already face high cost of medications, blood sugar monitoring, treatment of other diabetes related complications like neuropathy, retinopathy, nephropathy, or cardiovascular or cerebrovascular. Almost now 72 millions of people in India suffering from diabetes in 2023. Average total expenditure of the patient per month is almost a 1300, out of which medication expenditure is almost 1,000. Only a 271 they will be paying to a consultation or laboratory. Only a medical aspect is 80%. You can understand that. So if I say my patient to consult a dentist for your routine dental checkup, these numbers are not matching with that. They will not go for dental checkup if I suggest them to do that as well. So again, when the resources are for the doctor consultation like diabetologist, endocrinologist, or even MD clinician, then for the HbA1c, SMBG, or fasting PPBS, or RBS, or at least a creatinine, then the cost of the medications, and in spite of, if I'll add a dental consultation, then financial burden will be higher. So again, what are the accessibility and equality is also concerned. So universal periodontal therapy should be accessible to the health disparity. Many underserved population lack access to the dental care, and standardized therapy could further burden of these groups. Dentist unavailability in the rural area is a big concern. If we make it a plan in the standard care of treatment in type 2 diabetes, where is that availability of dentist in rural area like taluka level or beyond that? This is WHO data of India, where we can see over here. Yes. So in the policy, national health system response policies, the present third one, the presence of last one, so recognized as a national public health program. No, it's not recognized as a national public health program. If we see over here, the availability of dental assistant or any other dental technician out of 1 lakh population, there is 0. Only a 2 dentists available in 1 lakh population. So I think we are lack of resources and availability of dentist. Patient central care, as I said, one size does not fit to all, because not every diabetic patient experience severe periodontal disease, and the effectiveness of the periodontal therapy may be vary. Mandating it for all the diabetic patient may lead to unnecessary treatment, adding to a healthcare cost without guaranteeing an improvement in the health outcome. So, the regular monitoring of the blood glucose level, medication adherence, and lifestyle intervention are proven to reduce the complication and improve the patient outcome. So prioritize your fasting, PPBS, HbA1c, SMBG. Then there is a insufficient evidence to suggest that adding a standardized periodontal therapy would significantly improve the outcome in all the diabetic patients. Yes, in 2025, in standard care of diabetes, they have recommended in people with diabetes should be referred to a dental exam at least once per year, but it's not mandatory. The diabetes care guideline do not recommend mandatory periodontal care. Another aspect from the dentist point of view, if I'll see 100 patient per week and I'll refer that 100 patient to a dentist, then number of the patient in the dentist department will be higher, burden will be there for dentist. There are requirement of dental treatment in few patients which require like severe periodontitis is there or moderate periodontitis there. They require more time to treat it, but because of the burden of this patient, they will have a lack of time, and in that lack of time, they might miss something in whichever the required patient are treating, right? So each and every patient I cannot send to the dentist as well. Potential for overall medication, like adding more standardized treatment may lead to over medication. Yes, dentists will prescribe something to them. It is the clinicians like duty to have something to their patient. The pressure to follow a rigid treatment protocol and lead a unnecessary procedure to patients who do not need them, ultimately reducing the quality of care. Periodontal therapy should remain an optional, patient-driven choice. If patient has complaint, if you see something in patient, you refer to the dental. Pattern of disease and therapy for a diabetes along with the impact of generic prescribing a cost of treatment among the outpatient in tertiary care facilities where the pill burden remain high, adding more pill will improve the patient adherence? I don't think so. So, in the concluding remark, while a periodontal health is important for diabetes patient, I don't say it's not important. It's a very important. There is insufficient evidence to support the standardization of periodontal therapy within diabetes management plan. We should focus on the evidence-based, individualized care that prioritize patient's unique need, avoid unnecessary finances and treatment burden as well. Thank you so much.
Again, we have discussed ample, but still we would like to fall back on the policymakers. I'll quickly go back to the ADA 2225 again. Dental health professionals should be included in the diabetes care team. We are not there to debate. Detection from the clinician side is important. Why? Early you detect, early you're going to be referring out. This is what we are talking about. Early we refer out, early we catch the disease, and probably we cut down the dental expenses because, as rightly said by the chairpersons, neglect is not very important. I mean, you need to get it treated on time. So, more you neglect it, you are biting into your own pockets. Now, when we come to the dentist side, clinical assessment of the diabetic patients is mandatory. We need to understand that. The dentist should be informed by the clinician when he or she is referring or by the dentist. Kindly update the dentist about his or her diabetic history, what kind of medications a person is undertaking. Referral has to be there mandatory at least annually for the dental examinations. And once again, the gap is there. Let's try to slow down the gap or close down the distances by practicing something known as interdisciplinary interprofessional practices. That is the aim of all this, what we are talking about. So, quick, what is DIOH actually? Some are aware, some might not be aware. It's a specialty interest group under the aegis of Diabetes India, 16 specialty interest group, and that's the brainchild of Dr. Bansi. A big round of applause to DI for conducting this concept in India, which is a relatively new concept. And we have been given the responsibility to run the show. Few familiar names you can see. That's the team members that we are. Some are in the hall as well. So what it aims is devising patient education and motivational tools in clinical practices, sensitizing the awareness that we are talking about, collaborative clinical studies, some we have already undertaken and future plans in 2025 to pep it up again, scientific meetings and sessions and creating awareness through interdisciplinary forums. What have we done in the past few years? Some pictorials that you're seeing, conducting some online sessions, few webinars. We have created the patient education pamphlets, which will be released maybe 2025 soon. We conducted the national workshop cum symposium, which Dr. Anurag was mentioning, December, we undertook. And that's these few, pictorials from the last year's Bhubaneswar conference. We had a session just the way we are having session, and maybe next year we'll be showing some archives into our presentation next year. So these are the few future activities that we planned, and we should be documenting it maybe next meeting, then we see you. Till then, till we meet again, thank you so much for your lovely audience.